I want to thank you again for inviting me to be part of your conference, and I'll be speaking to you today about neuraxial block and should it be retired. I have no financial disclosures, and I thought I would start out my talk just by discussing what is major abdominal surgery. And I think that for many of us who practice anesthesiology, I think we automatically assume that this is major open laparotomy, emergency surgery for cancer, for example. And these are the visions that I think we tend to take into account when we try to decide what would be the best analgesic approach for our patients. If you look at some of the published guidelines, this one came out 2 years ago for enhanced recovery after colorectal surgery. We know that thoracic epidural analgesia is considered the gold standard for major open abdominal surgery. And there are several guidelines that attest to the same recommendation. However, a couple of years ago for the American Society of Anesthesiologists annual meeting, I had asked my followers, what type of regional analgesic technique would you want if you or a loved one had to have major open abdominal surgery, such as a Whipple procedure, a distal pancreatectomy, or gastrectomy? Assume that the person is healthy and not anticoagulated. And you'll see the results of this poll, which had 560 votes. It was overwhelmingly in favor of thoracic epidural. So I think that we as anesthesiologists also ascribe to the fact that a thoracic epidural for major open abdominal surgery is most likely to provide the best analgesia when properly sited. However, we know that surgery itself is changing. And so even for procedures that we would have considered automatically open via a laparotomy approach in the past, such as Whipple for cancer surgery, are now being performed robotically. And I think we're going to see more and more of our surgical procedures going the minimally invasive route. As most of these surgeries start to become less invasive, do they still require an epidural, especially when you keep in mind the expectations for enhanced recovery and early mobility? When we look at published studies on major open abdominal surgery, those surgeries that we would consider eligible for thoracic epidural, you'll see that the rates of epidural use are incredibly low. Only 15% for colectomy, 19% for distal pancreatectomy, only 23% for pancreaticoduodenectomy. So the great majority of patients, the large portion of the iceberg under the water, are major abdominal surgery patients who do not get an epidural. And I think there are a lot of reasons for this. Some of it, of course, are technical issues. The problem with epidurals is that they don't always work. And I think when you spend the time to place an epidural before surgery and the epidural fails afterwards, this is not a good way to sell and convince your patients and your surgical colleagues that this is the right technique for every patient. With failure rates of 32% for thoracic epidurals, even 27% for lumbar epidurals reported in the literature, this is of great concern, especially when we know these types of major abdominal surgeries will cause our patients a great deal of pain and affect their recovery. So much so that we've seen I think these types of editorials from very well-respected colleagues like Professor Verwal have said that while we need to consider epidural as the gold standard, perhaps there are alternatives that are starting to emerge, such as the use of fascial plane blocks that may be effective, at least as effective, especially in the context of multimodal analgesia, and perhaps even safer than epidurals, given that they have risks in the patients who are on anticoagulation, and of course, the risk of failed block. The other issue that we have, at least in the United States, is that training in thoracic epidural analgesia is still very limited. And it's becoming more limited as surgery starts to move in this direction of minimally invasive techniques. Right now, our expectation for residents in the United States is to have 40 experiences with epidural placement before they finish residency. And this number, 40, actually does not specify thoracic epidural analgesia, which we know to be a much more difficult procedure technically than lumbar epidural placement. So one question in my mind, as we start to think about the role of epidural analgesia, and particularly thoracic epidural analgesia for the future of surgical analgesia in the context of major abdominal surgery, is there a role for subspecialists? Because if our residency graduates, the general anesthesiologists in practice, they lack sufficient experience and training in thoracic epidural analgesia, perhaps there's a role to train our regional anesthesiology and acute pain medicine specialists to be experts in thoracic epidural analgesia in addition to peripheral nerve blockade. If we look at some of the published studies, we know that image guidance can assist in the correct placement of thoracic epidural catheters. And this is essential, especially for those major operations, those large open cancer cases that require a large laparotomy incision. Those are the patients who are going to benefit the most from a thoracic epidural. And for those patients, that placement of the epidural has to count. How many residency graduates can reliably perform image-guided thoracic epidural catheter placement? I would argue very, very few. During a subspecialty year, for example, during fellowship in pain medicine fellowship trainees learn a great deal about fluoroscopy for placement of injectate for patients with chronic pain. In acute pain, there has not been the same emphasis on the use of fluoroscopic guidance for neuraxial anesthesia. However, I would argue that as we start to move towards subspecialization for thoracic epidural analgesia, this may become a necessity. We know from radiologic studies that when thoracic epidural catheters are placed under fluoroscopy, they're not only placed correctly, but the injectate that is injected via the catheter can actually spread multiple levels. You'll see here in this particular study published a few years ago that on average, 4 to 5 levels of spread can be accomplished with just 2.5 milliliters of dye, which I think is very impressive for a correctly sited catheter. If we start to look at our alternatives, then I think that the norm today for pain management after surgery is multimodal analgesia. And that means using multiple different modalities to try to minimize the reliance on opioids for pain management. And this can come in the form of non-pharmacologic interventions like cognitive behavioral therapy, patient education. We also know that we have non-opioid systemic analgesics like acetaminophen. We can use NMDA antagonists. We can use anti-inflammatories for some cases. We can also use gabapentinoids when they are indicated, and of course opioids, which still represent an important class of analgesics. But we should also use local anesthetics. Neuraxial techniques like epidural analgesia may be indicated, as we've talked about, but there are other modes of local anesthesia delivery that we should also start to consider as well. And one of these classes of local anesthetic techniques and new regional analgesic techniques are the fascial plane blocks. And today, there are many, many alternatives to epidural analgesia in the form of regional analgesic techniques of the fascial plane. And they seem to be more and more all the time. Now that we have ultrasound, we can identify multiple different fascial planes in the body and use them as targets for local anesthetic deposition. And when we look at this figure again, if you consider the very low percentage of patients having major abdominal surgery who get an epidural, rather than looking at the bulk of that iceberg as being patients who don't get an epidural, we should look at them perhaps as opportunities to give them some other form of regional analgesia. So if that percent of patients who gets an epidural remains low, then the majority of patients shouldn't be devoid of any regional analgesia at all. They should be offered something as an alternative. And I think that fascial plane blocks may be that alternative that patients can have access to. This takes a different approach in terms of training our anesthesiologists of the future. It means that we have to focus on basic blocks that every anesthesiologist should know how to do. And in this editorial that I wrote with 2 of my colleagues in the UK, we proposed what we called the Plan A blocks, or a set of blocks that every anesthesiologist should know how to do. Blocks for knee surgery, hip surgery, shoulder surgery, distal upper extremity surgery, foot surgery, and we also suggested abdominal surgery. And amongst the techniques that you may choose from in order to provide analgesia of the abdominal wall or trunk, we suggested fascial plane blocks. In the article, we talk about the rectus sheath block, which essentially is a form of the tap block. And if you look at the tap block, what makes it so attractive is that it can be learned very quickly. In this surgical simulation study, they found that in just 4 attempts, that a new practitioner could perform bilateral tap blocks in 6 minutes or less, including setup time. I think it's very hard to argue, with that type of a steep learning curve or a rapid learning curve in being effective in terms of training and a basic block that anesthesiologists can master before they finish their training programs. If we think about how well these techniques can work, we also have to remember that they don't work alone. So a tap block by itself may not be complete analgesia for a major abdominal surgery, since it does not cover visceral pain. However, this is not the only modality that they receive in a multimodal regimen, of course. If you look at the pain control that patients receive from a tap block in the multimodal analgesic regimen, we'll see that compared to epidurals, at least in this large study of over 400 patients, the pain scores were actually equivalent between patients who received tap block and patients with a catheter and patients who received epidural analgesia. I also think it's important to think about ways that we can continue to improve our analgesic regimens for patients. This is an editorial that I wrote with one of my colleagues, Jody Lang, and it was interesting because the article that we were actually commenting on had a very robust multimodal regimen. This is the multimodal regimen at Rush University, in which all patients having bariatric surgery receive local infiltration by the surgeon. They receive dexamethasone, ketamine, acetaminophen, and opioids. And what was interesting about their study is that when they took that very robust multimodal regimen and they added tap blocks on top of all of that, they still saw improvements, 9% and 11% based on the type of surgery in terms of opioid reduction. And so I still think that the tap block has some marginal gain when it comes to improving multimodal analgesia, and can offer in the scheme of multimodal analgesia effective pain control for patients having even minor and major abdominal surgery. We still have a lot to learn when it comes to fascial plane blocks. Right now, if you think about how many new fascial plane blocks we have available, it does not match our understanding of the anatomy and the dynamics of fascial plane anatomy in terms of local anesthetic techniques. We still need more research, of course, in this area, because we don't fully understand what the mechanism of action is of many of these blocks. While the cutaneous distribution of these blocks tends to be highly variable, we know that they do successfully achieve muscle relaxation of the abdominal wall, and perhaps that muscle relaxation is responsible for much of the analgesia that leads to decreased opioid consumption in many of these patients who receive fascial plane blocks for abdominal surgery. So I'll leave you with that. If you scan the QR code, even though I can't be there with you in person, I hope you'll take a virtual visit of our program here at Stanford. This is a short video that we created as a virtual visit to our campus for many of our fellowship applicants who apply to regional anesthesiology and acute pain medicine. And hopefully one day I'll have a chance to visit you all in person. Thank you very much.